Hello, I am Dr. Nesmani. This is the continuation of the analysis of ECG, which is a series of ECG tutorials regarding the basic principles of ECG analysis. The Joint Task Force further refined the definition of myocardial infarction by developing a clinical classification according to the presumed proximate causes of the myocardial ischemia, type 1, 2, 3, 4 and 5. Type 1, that is myocardial infarction consequent to a pathologic process in the wall of the coronary artery like a plaque erosion, rupture, fissuring or dissection. Type 2 means MI consequent to increased oxygen demand or a decreased supply like a coronary artery spasm, coronary artery embolus, anemia, arrhythmias, hypertension or hypotension. And type 3 is sudden unexpected cardiac death before blood samples for biomarkers could be drawn or their appearance in the blood. Type 4 and B, 4A means myocardial infarction associated with the percutaneous coronary intervention. And type 4B means myocardial infarction associated with stent thrombosis, and type 5 means myocardial infarction associated with coronary artery bypass graft surgery. Now, what is this hyperacute T waves? The earliest signs of acute myocardial infarction are subtle and include increased T wave amplitude over the affected area. The T waves become more prominent, symmetrical and pointed. The T waves become more prominent, symmetrical and pointed, what is called hyperacute T wave. Hyperacute T waves are most evident in the anterior chest leads and are more readily visible when an old ECG is available for comparison. These changes in T waves are usually present for only 5 to 30 minutes after the onset of the infarction and are followed by ST segment changes. Hyperacute T wave change is just for 5 to 30 minutes and followed by ST segment change. Now, what is this ST segment change in myocardial infarction? In practice, ST segment elevation is often the earliest recognized sign of acute myocardial infarction and is usually evident within hours of the onset of symptoms. Initially, the ST segment may straighten with the loss of the STT wave angle. Then the T wave becomes broad, ST segment elevates, losing its normal concavity. As further elevation occurs, the ST segment tends to become convex upwards. The degree of ST segment elevation varies between subtle changes of less than 1 millimeter to gross elevation of more than 10 millimeters. So in this picture I am showing the normal ECG, then peaked T wave, then the degree of ST segment elevation, the three pictures you can see, then the Q wave formation and loss of R wave, then the T wave inversion. These are the sequences of changes seen during evolution of myocardial infarction. This picture should be memorized. Okay. Now, anterior wall infarction with the gross ST segment elevation is shown in your picture, showing the tombstone R wave. See the leads V1 to V6 in the picture. Sometimes the QRS complex, the ST segment and the T wave fuse to form a single monophasic deflection called a giant R wave or a tombstone R wave. So that is very clear in the picture. Now, pathological Q wave. As the acute myocardial infarction evolves, changes to the QRS complex include loss of R wave height, loss of R wave height, and the development of pathological Q wave. Both of these changes develop as a result of the loss of viable myocardium beneath the recording electrode, and the Q waves are the only firm electrocardiographic evidence of myocardial necrosis. Q waves may develop within 1 or 2 hours of the onset of symptoms of the acute myocardial infarction, so often they take 12 hours and occasionally up to 24 hours to appear. Presence of pathological Q wave, however, does not necessarily indicate a completed infarct. If ST segment elevation and Q waves are evident on the electrocardiogram and the chest pain is of recent onset, patient may still benefit from thrombolysis or direct intervention. When there is extensive myocardial infarction, Q waves act as a permanent marker of necrosis. With more localized infarction, the scar tissue may contract during the healing process, reducing the size of electrically inert area and causing the disappearance of the Q waves. The pathological Q wave is shown in the picture in the inferior and anterior leads. The resolution of changes in ST segment and T waves. As the infarct evolves, the ST segment elevation diminishes and the T wave begin to invert. The ST segment elevation associated with an inferior myocardial infarction may take up to 2 weeks to resolve. ST segment elevation associated with anterior myocardial infarction may persist for even longer. And if a left ventricular aneurysm develops, it may persist indefinitely. T wave inversion may also persist for many months and occasionally remains as a permanent sign of infarction. The reciprocal ST segment depression. ST segment depression in leads remote from the site of an acute infarct is known as reciprocal change and is a highly sensitive indicator of acute myocardial infarction. Reciprocal changes are seen in up to 70% of inferior and 30% of the anterior wall infarctions. Typically, the depressed ST segment tend to be horizontal or down sloping. Presence of reciprocal change is particularly useful when there is doubt about the clinical significance of ST segment elevation. The picture shows an inferolateral myocardial infarction with reciprocal changes in lead 1, AVL, V1 and V2. Reciprocal change strongly indicates acute infarction with a sensitivity and positive predictive value of over 90%, though its absence does not rule out the diagnosis. Pathogenesis of reciprocal change is uncertain. Reciprocal changes are most frequently seen when the infarct is large, and they may reflect an extension of the infarct or occur as a result of coexisting remote ischemia. Alternatively, it may be a benign electrical phenomenon. The positive potentials that are recorded by electrodes facing the area of acute injury are projected as negative deflections in leads opposite the injured area, thus producing a mirror image change. Extensive reciprocal ST segment depression in remote regions often indicates widespread arterial disease and consequently carries a worse prognosis. The picture shows the reciprocal changes, presence of Widespread ST segment depression in the anterolateral leads strongly suggest that septal inferior ST segment elevation is due to acute infarction. Localization of site of infarction. The distribution of changes recorded in acute myocardial infarction allows the area of infarction to be localized, thus indicating the site of arterial disease. Proximal arterial occlusions tend to produce the most widespread electrocardiographic abnormality. The anterior and inferior aspect of the heart are the areas most commonly subject to infarction. Septal infarcts are highly specific indicators of disease of the left anterior descending artery. Septal infarcts are specific for disease of left anterior descending artery. Isolated inferior infarct changes in lead 2, 3 and AVF are usually associated with the disease in the right coronary or distal circumflex artery. Inferior 1 infarct change in 2, 3 AVF leads means right coronary or distal circumflex artery. Then disease in the proximal circumflex artery is associated with the lateral infarct pattern, that is lead 1 AVL, V5 and V6. Proximal circumflex artery, lateral wall infarction, lead 1 AVL, V5 and V6. The ECG tutorial continues in the subsequent videos, so please visit the site youtube.com/acpgmed or facebook.com acpgmed. Thank you.